So good evening, everyone, and welcome. We're going to just wait a couple more minutes and enter the last few guests, and we'll get started about 7:03. So thank you so much for being prompt and on time, and we'll get started in 2 minutes. Hi, Anna. There she is. Good evening, Anna. About 1 more minute. All right, so I see my clock has turned to 7:03. So I'm going to go ahead and get started and say welcome to everyone and to tonight's Family University. Before we get too deep into this, I'm going to give Carmen an opportunity to ask if anyone needs translation in Spanish.
Sí, muy buenas tardes. Me llamo Carmen y estoy aquí para asistir. Si necesitan traducción en español, por favor díganme ahora. ¿Hay alguien que necesite traducción en español? Okay, no responses yet.
Thank you, Carmen.
Thank you.
So my name is Kelly Gradstein and I work for Temecula Valley Unified School District. It is my pleasure to welcome you to Family University this evening and to this conversation. We are really, really excited to welcome you here tonight and to have this conversation. This is a topic that we haven't had the opportunity to cover for a while. And so we are so just pleased to be here and have the opportunity to talk about this really important topic. With a Family University, our goal is to educate. Our goal is to share information. And so we are so thankful for you taking the time to be here tonight to listen to this information, because we know that knowledge is power. And the more we know, the more we can help our students and our kids and, help them to be successful individuals and grow up to be great, healthy, happy adults. So before we get into the presentation, I just want to remind you that this is being recorded. So we ask that if you answer any questions or if you ask anything, that you keep the name of your student private. We would never want to divulge any information about any of our kids in a public format, because this video will be shared with others who ask for it later on. So we ask that you just kind of keep it generic when you are referring to your student or any questions that you might have. If you want to keep your video off, that's really fine. We understand that a lot of you are doing other things. You might be cooking dinner or riding your bike, exercising, those kinds of things. We really just appreciate you being here. Before we get started, just a couple more things. I'm going to say thank you to Lisa Bronson, who's on. Lisa actually connected us with the Center for Discovery. She's one of our SEL team members, and she works at Temecula Luis Seño Elementary School. So thank you, Lisa. And I also want to thank Elizabeth and Giselle, who are here, or Elizabeth and Shantae, who are here as our presenters this evening and moderators, just to share this information. They are joining us from the Center for Discovery. And so I'm going to pass it off to them. And again, just thank you both for being here and being willing to share this information with us. Can't wait to hear what you have to share tonight.
Thank you so much. This is quite an honor to be here. Thank you for everyone who has attended. And to go off of Kelly's share, if you do have a specific question that you feel like you don't want to ask in a public format like this, because it is going to be shared, I'm also going to be giving out my information and Shantae's information at the end of the presentation. So if you did want to get some further insight or some clarity, you can also reach out directly. Okay. And then also we will have a Q&A at the end of the presentation. My name is Elizabeth Giselle. I'm an LMFT and clinical outreach representative at Discovery Behavioral Health. And I am so happy to be here with my esteemed colleague who I admire very much, Shante Parker, who is a clinical outreach representative also at Discovery in the Temecula area overseeing mental health and substance use. Shante, would you like to say hi before we start the presentation?
Everyone, I'm very pleased to be here, and we have a great first presentation. Elizabeth is amazing, so thank you for joining us.
Thank you. All right, so I'm going to be sharing my screen. So I have a presentation that you'll be able to see visually. And then if anybody has any questions, I'm not going to be able to see you nor the chat while I'm presenting. So please, you can still put it in the chat. I just might not see it at that moment. We can visit it during the question time, or you can write it down to remind yourself and then share it during the question period. But if you've put something in the chat and I don't see it, that's why. So I'll share my screen right now. All right. Here it is. All right, so today we're going to be discussing eating disorders, how to support our children. A little bit about myself, the speaker. My pronouns are she, her. As a therapist, I've worked in an elementary school and middle school setting, a homeless shelter for women and children, and at Discovery Behavioral Health, I have worked as a primary therapist at our eating disorder, PHP, and IOP program. You'll learn a bit more about what PHP and IOP is later on in the presentation, and also as a program director of our mental health California virtual program. I'm currently a PhD candidate, which means I've completed all my coursework and passed the exams, but I am not done yet, and I am not a doctor yet. I'm going to be working on my dissertation towards my doctorate in the future. At Discovery, my role is a clinical outreach representative. This means that I collaborate care for the community within triage of care. So say somebody needs a higher level of care or a lower level of care, I can help out with that. I collaborate with doctors, therapists, nutritionists, and families. I'm also a mother and passionate about the well-being of children. These are the topics that we're going to be exploring today. We're going to be talking about eating disorders, red flags of eating disorders, diet culture, wellness culture, fostering a healthy relationship with food within your home and within your families, levels of care, supporting our children and also ourselves. We'll have a Q&A, and then I also have resources for you all. All right, so let's talk about eating disorders. On the surface, disordered eating, it's a disordered eating pattern which leads to health consequences. Now, at the core, eating disorders can be a distraction from something else. It can be considered a coping skill. Though it's a maladaptive coping skill, it could be a coping skill and also a communication to underlying mental health challenges. Oftentimes, eating disorders can be referred to as a silent scream because they're very, very loud, but they can also be silent. Oftentimes, there's a lot going on underneath an eating disorder behavior. Kind of like the eating disorder is the tip of the iceberg, and there's a lot going on underneath the ocean. 9% of the US population, that's around 28.8 million Americans, will have an eating disorder in their lifetime. So eating disorders are not uncommon. Less than 6% of people with eating disorders are medically diagnosed as underweight. I think this is important to share. So oftentimes when we think of eating disorder, oftentimes the visuals that come to mind or that you may see in media is somebody who is significantly underweight. And that is less than 6% of people who have an eating disorder. Eating disorders are also among the deadliest mental health illness, second only to opioid overdose. Just taking a moment right now because I'm sharing some information that is hard, more difficult. 10,200 deaths each year, and this is in the United States, are the direct result of an eating disorder. That's one death every 52 minutes. I just want to take a moment to recognize that and honor those lives as well. So we know that eating disorders impact this country, impact our communities. It is very hard to find somebody who hasn't been impacted by an eating disorder, whether it's from personal experience or someone that they love, someone in their lives. We're going to learn a little bit about different kinds of eating disorders now. We'll first learn about anorexia nervosa. This is the restriction of food leading to significantly low body weight. It's an intense fear of gaining weight or becoming quote unquote fat, even when underweight. There's disturbances regarding weight or shape and denial, distortion of low weight. This might be someone they might look in the mirror and they, what we would call body dysmorphia, where they wouldn't see what the reflection is in the mirror. They may see their body very, very differently than what others may see. When people have anorexia nervosa, they can have either restricting or purging type. Restricting would be restricting of caloric intake or restricting of food. Purging is referring to throwing up, or you can also purge through exercise, and you can also purge through laxatives. There's different ways of purging that people may engage in. Bulimia nervosa is experience or perception of having a lack of control over eating while eating a very large amount of food during a short period of time. This is what's referred to as a binge. Now, after the binge, there would be a recurrent compensatory behavior to prevent weight gain. This would be purging, restricting, laxatives, exercising. Binge eating disorder, it's also, we call it BED sometimes. This is experiencing a perception of having a lack of control over eating while eating a large amount of food, very similar to the first one that we just talked about before, binging, at minimum to once per week for 3 months. And at least 3 of the following: eating until overly full, eating when not hungry, eating rapidly, eating alone due to embarrassment, feeling guilty, depressed, or disgusted afterwards, and there's no compensatory behavior following. For instance, like the purging or the laxatives. Avoidant and restricted food intake disorder. This is also called ARFID. We're seeing a lot more of this than we've seen in the past. This is restriction of food leading to being either significantly underweight, nutritionally deficit, reliant on nutritional supplements, or impaired psychosocially. Not attributed to medical condition and may be related to being excessively picky, having sensory preferences. You may notice like, oh, I don't like the way that feels, or like when it comes to a certain kind of food. And then this also can happen if somebody's had an incident of choking or an adverse consequence of eating in the past. The last one I will share is other specified or unspecified feeding or eating disorder. This is newer. This is a newer disorder. And this is an eating disorder that's been classified as a newer eating disorder in the DSM. This is an eating disorder that causes significant impairment, but does not meet full criteria for above diagnosis, such as atypical anorexia, bulimia nervosa, or BED, which is binge eating disorder with low frequency. We're grateful as therapists and in the mental health community that this is now a diagnosis, because this means that people who, for instance, they may have anorexia, but they don't have significantly low weight, they can still get treatment. And that's really important. Now, something that I think is important to share is that all genders, ethnicities, and socioeconomic backgrounds can have an eating disorder. A common misconception is that eating disorders only affect wealthy, heterosexual, white, cisgender females. This is not only inaccurate, it's also harmful. I'm just going to share a little bit about some statistics. Of the 30 million Americans with eating disorders, only 20% ever receive treatment. The other 80% do not receive treatment due to stigma, misconceptions, lack of education, misdiagnosis, and lack of access to care. Now, we're doing things to advocate and change that, and I'll share a bit more about that later in the presentation. But I just wanted to share this because it's not like, oh, you know, like for instance, like boys can have an eating disorder. But non-binary people can have an eating disorder. Trans people can have an eating disorder. All ethnicities, all religions. It's not like it's just one population. And it's really important to know that, because if we think it's only one population, then there's a whole bunch of other people that are not going to be able to be treated and get the care they deserve. Let's talk a little bit about psychological aspects of eating disorders. When it comes to binge eating and or purging, this can reduce anxiety temporarily, but reduce anxiety associated with trauma. It tends to numb and create an avoidance of the feelings from the trauma. It's just a little bit of insight, because someone might say, oh, why are they binging? Or why don't they just stop? Or why are they purging? Why don't they just stop? Don't do that. But oftentimes when we have something happen, it's because it is serving some type of purpose, even if it's not good for us. And so to have that kind of insight can be helpful. Emotional challenges such as depression, anxiety, irritability, and anger can coexist with eating disorders and be a contributing factor. Oftentimes, if somebody tends to be a people pleaser, who are avoidant of conflict and normal negative emotional reactions, they can have a tendency to have obsessions or rigidity, and are prone to perfectionism, may have a higher risk of developing an eating disorder. This is also a contributing factor to eating disorders not being diagnosed. Because say there's a student getting all A's, doing everything quote unquote right. The teacher is like, wow, this is just amazing. The student is just always excelling. Well, they're people, they may be perfectionists, they may have perfectionism tendencies. They may be presenting like they're doing really, really well, but the eating disorder may be the silent scream that is actually sharing, I'm not doing so well. I might just be scared to vocalize it. Other psychological aspects of eating disorders: major life changes, stress, lack of control over certain situations. The onset of puberty can be very difficult for teens, and that can be a contributing factor to an eating disorder, especially in the trans community, non-binary community. That can also be a triggering factor that can contribute to an eating disorder on the onset of puberty. History of teasing, cultural, societal pressures for thinness, it's everywhere. And we'll talk a bit more about that later on in the presentation. Genetics, family history of anxiety and eating disorders can be a contributing factor, and dieting. That is the #1 predictor of eating disorders. Common family dynamics with eating disorders are avoidance to negative emotions, pride in handling hardship without displaying pain or complaining, like stiff upper lip type mentality, or like, oh, you can go through some hardship and you don't complain about it. That can be a contributing factor to dynamics within eating disorders. This is also a great emphasis on displaying as happy. You don't necessarily have to be happy, but if you look happy, then that's what we're going for. So that kind of pressure can contribute to an eating disorder as well. A great emphasis attached to high achievement, parental criticism, ignoring, dismissing, and trivializing or punishing emotions in general. When we have an emotion, if we're not able to express it in a healthy way, it will find its way to pop up. Maybe not in quite the healthiest way. All right. Eating disorder red flags and behaviors. Now I'm going to go through this list. When I go through this list, I think it's important to know, like, oh, if it's not like, oh, that I know somebody has that on the bullet point, it doesn't necessarily mean they have an eating disorder. Okay. These are just possible red flags. And if you're seeing them, it's important to, especially like in your child, it's important to have more curiosity. All right. It doesn't necessarily mean, oh no, but just having curiosity in regards to it. Significant weight loss. That one would be a big one. If your child is losing significant weight at a rapid pace, that would be of concern. You would definitely want to go to the doctor. You want to take your child to the doctor. Orthostatic vitals, dizziness, fainting, another concern. Loss or delay of menses, that is one's period for people who have ovaries and ovulate. Abnormal lab work, compromised immune system, low heart rate, and cardiac arrest. Cardiac arrest is one of the leading causes of death for eating disorders. It may be cardiac arrest that ends the life, but the contributing factor is the eating disorder. Becoming tearful, emotional around food, strange food combinations. So the first part that I shared is more like serious matters that you want to get medical intervention. Some of these other pieces, you may want to just have a bit more curiosity, reach out to your school counselor, and keep an eye on it. Strange food combinations, difficulty concentrating, eating too slow, eating too quickly, plating inappropriate large or small portions, eating with extreme imbalance, lack of variety, staring at food, obsessing about what they want to eat. When people are very hungry, oftentimes the brain will obsess about food, and it makes sense because they're hungry. And so sometimes people who aren't being fed enough nutrition, they'll be watching tons of food shows, or maybe even cooking themselves and feeding everyone else, but they're not eating the food that they're making. Hiding food and consuming it, maybe in hiding, like stealing it to eat it by themselves. They may spit out food, hide it in a napkin, pacing or excessive standing, shaking of the leg, micro exercising. That's like, for instance, like say you're standing in line at the grocery store and you start doing leg lifts. Water loading, it's like drinking a whole bunch of water. Fluid restricting, that would be like not having enough fluid in your body intake. Wanting to use the bathroom right after meals. Micro biting, cutting, or taking too large of bites. Obsessive body checking, like always looking at yourself in the mirror, always checking your body. Eating past the point of fullness. Rules around when to eat and when not to eat. And talking negatively about food in general. Those are just some of the red flags. The earlier ones, I just want to reinforce, for instance, like when it comes to abnormal lab work and things of that nature, it is important to see medical attention. Some of the other ones, like for instance, eating what would be seemed too slowly, or strange food combinations, that might just be more of a red flag. Like, I just want to keep an eye on this, or have some more curiosity in regards to my child. Perhaps speak to a counselor at school. All right. Let's talk a little bit about diet culture. This one, I'm not happy about this one. Diet culture is all around us. It's a system of beliefs that value thinness over health and well-being. It equates thinness with health, moral virtue, and equates larger body people with having not as much health and moral virtue. This is also called thin privilege and fat stigma. Diet culture is everywhere. It's in our TV shows, on social media, on the billboards. It's living in our society. It is pretty much impossible to get away from it completely. It is constant messaging, and it does affect our children. It also affects ourselves. It's almost impossible to not be impacted by it in some way. One of the strengths is recognizing it and knowing when you see it, like, okay, I know when I see this on a billboard, I'm seeing this on an advertisement, what kind of messages, and do I buy into this message? And I think it's important to know that, society may have a message that does not serve your family, but you can have a different value system at home. Diet culture promotes a concept that there is something intrinsically wrong with some bodies, and that is completely false. There's no good bodies and bad bodies. All bodies are beautiful and worthy. And so so for instance, like diet talk in the home of that nature, that would be contributing to diet culture within the home. We may not always have control over what is all around us in society, but we can make adjustments within our home. Wellness culture. This is something important to talk about too. This elevates certain ways of eating while demonizing others and can place moral virtue onto the individual based on what they eat and what they do not eat. You might hear like something like, I eat only organic, or I eat quote unquote clean. And oftentimes the wellness culture is kind of promoting a type of elitism. Like, oh, I'm better because of this. And this promotes a concept that there's something intrinsically wrong with some food. This is also this is a bit more sneaky than diet culture, because diet culture is in our face and it's much more obvious, but wellness culture can seem like it's showing up well intended. I mean, with the word wellness culture, but it can be a contributing factor that can contribute to eating disorders. This, I think, is important to note. The weight loss industry will bring in $3.8 billion. It's a lot of money in revenue in the US market in 2003 alone. The industry makes money by telling people that there's something wrong with their bodies if they do not attain a thin ideal. Now, seeing that, marketing and advertising, they have a lot of financial reinforcement to make people think there's something wrong with their body and they need to change it. And I think that's important to know, because if you feel like there's a moment where you see something or you feel like there's something wrong with your body, it's also really important to know that there's a huge industry out there that wants to profit from that. And so there can be a shift sometimes, especially when I've worked with children and adults, when they recognize that that piece of empowerment, to not have those type of industries control how they feel about their body or influence them in that in a harmful way. Let's talk about fostering a healthy relationship with food. Only compare your child to your child. That is so important. Children come in all different sizes. We're meant to be that way as human beings. And so when it comes to height and it comes to weight, it is really important for us to not compare our children to another child. Even when it comes to the growth chart that you'll see at like when they go to the doctor, there's all different kinds of percentiles. It's really important for a child to stay within their percentile. If there is a big shift up or a big shift down, that would be something to talk to your doctor about. But if, say, you have a child that's on the 70th percentile and they stay around that range the whole time, great. If you have a child that's in the 40th percentile and they stay within that range, great. It's really about a big, like a dip either way where there's a red flag. We don't want every child at the 50th percentile. That would make no sense. And that actually that's not how human beings work. We're not all supposed to be the same size. That's why 50 percentile is like an average of all of them, but we're supposed to land in all different parts of that chart. Avoid diet talk and behavior within the home and around your child. Develop an all foods fit mentality. This is the concept. There's no good foods, no bad foods. Food is food. Do not tell children that they are overweight or underweight. Creating a safe space to discuss emotional challenges they may experience as their bodies change. It's talking about puberty. Talking it in a way that's not shameful, and giving them space to talk about the changes that are going on in their bodies. Providing your child with a variety of foods, which includes carbohydrates, proteins, fats, water, and also love. That's important too. Intuitive eating. Trusting your children to listen to their hunger cues and honor them. Do not force your child to eat through punitive measures. When it comes to eating disorders, sometimes children can lose their hunger cues. Also, adults can lose their hunger cues. If we have hunger cues and we do not honor them, it is more likely for us to not be able to recognize them anymore. It's kind of like if the body's like, hey, I'm hungry, I'm hungry, I'm hungry, and you're not listening to it and you're ignoring it, sometimes the body will stop telling you. When somebody has that, we do have treatment that will help them gain their hunger cues back and learn to honor them. Do not put your child down emotionally. This one says while at a meal, but I would say also just in general. I realized that when after I put that on there. Do not put your child down emotionally while at a meal, but also just in general. Provide a calm, relaxed environment around meals and snacks, and developing a health in every size mentality within the family. The concept that all bodies are good bodies within weight inclusivity. Model a health in every size and all food fit mentality for your child. This would include not weighing yourself in front of your child, talking about dieting, or like good, bad foods. Just a note about the weighing yourself. So like, for instance, at Discovery, we will weigh someone, but they don't see the number. We see the number, but they don't. Levels of care. Placement for eating disorders is based on APA guidelines from the state of California. And the reason why they have it this way is so it benefits the health and wellness of the community. And so it's not opinion based. It's not like, oh, your kid or you need, RT residential. And it's just based on opinion. It's actually based on certain guidelines. And that's what mental health facilities and professionals adhere. Outpatient would be working with, like, for instance, a counselor at the school. And that would be seeing somebody maybe once to twice a week for a session, maybe a family session, individual session for therapy. Discovery offers the next 3 levels of care. We do not offer outpatient, but we collaborate with outpatient therapists. The next level of care would be a step up, and that's intensive outpatient. That would be like an afternoon program or a morning program. It's usually about 3 hours, and it's usually about 3 to 5 days a week. It varies on the program. Partial hospitalization, that's also called PHP, and that's like an all-day program, all right? But the child would go home at night and stay at home with the family, and then they go in during the day. PHP is usually either 5 days a week, 6 days a week, and some programs are 7 days a week. Residential, that's where a child would go to a house type setting, and they would get treatment around the clock there, and they would sleep there as well. That type of program, the houses feel comfortable, so they don't feel like a hospital. They feel like they have a full clinical staff and support for the eating disorders, but they're like in a home environment with peers that are around their age. And then we have inpatient hospitalization. This would be a hospital. Oftentimes it's for more, not oftentimes, this would be for more severe cases. And that would be, say a child needs a weight restoration, maybe they need tube feeding, maybe they have certain lab work or heart rhythm that they need to tend to and medically in a hospital, then they would go inpatient. Residential sometimes also offer tube feeding. So that if the residentials that offer tube feeding would be something like kind of like in between that residential and inpatient. Some of Discovery's places have tube feeding as well. Let's talk about education. We're doing a family night for Temecula Unified School District. So let's talk about education, which is so important. When it comes to programs, IOP, PHP, and RT's levels of care, it's important to have education liaisons. And what these people do is they support the adolescents, their educational needs, and collaborate with schools for academic success. It's important to note that mental and medical health of the patient take precedent over education. Oftentimes when a kiddo is going through treatment for an eating disorder, their schooling is not going to look the same. There's going to be either a halt in it, or there's going to be where they're going to be working less on it, and they're focusing more on their mental health and their physical health and their well-being and that nature at that time. Now, once a child is recovering, they're more likely to have academic achievement than if they prioritize the academics over the recovery initially. So even though at first it may seem like we can't have them get that care because, oh, they have to do this, they have to do this for school. Oftentimes what we actually see is that when a child gets the care they need for their eating disorder, then they're able to return back to school and have more academic success than if they weren't able to get the treatment. Supporting our children and ourselves. This part, so I feel like is so important. I think so much parts of this is important, but forgiving yourself. We're all human and we all make mistakes. If there's something that I've mentioned during this presentation and you're like, oh, I did that, or I complained about XYZ on my body, or I was talking about my diet, or something that you feel like, oh, maybe I shouldn't have said that. This is the time to forgive yourself and realize we all make mistakes as parents. And what's important is as we learn new information is to continue that curiosity and continue to educate yourself on how to best support your family and your children and yourself. Children do not want to have an eating disorder. This is really important to know. They are not doing it on purpose. If your child is restricting, it's not as simple as just eat something. Not that simple. And they're not doing it to spite you or to rebel. They're not wanting to have an eating disorder. It's not as simple as just saying eat something. It's important to reach out for help. Community support is so important. When it comes to an eating disorder, it is really important to reach out for professional help. You can reach out to your counselor at Temecula Unified School District. If you don't have a counselor, getting a counselor. I'm also going to give you some more resources after this presentation, and I'm also going to give you my direct line as well. Be gentle with yourself and your child through authoritative parenting. Creating a safe space with our children can express their thoughts and feelings. Getting your own support as parents, so important. Parenting is hard. Being a human being has challenges in general. So having that support through groups and therapy. Reaching out to counselors on your campus for support. And at this part, I'm going to take any questions. I'm going to stop my share for a moment so I can have my focus on you all. And if anyone has any questions, you can either put it in the chat, or you can also unmute yourself and ask away. If you have a question that you feel more comfortable asking in a more private setting, you can reach out to me with my direct contact after this part that I'll share. Does anybody have any questions? Any clarifications? Oh,
I have
hi.
a question. Hi. Any guidelines and recommendations if your child's on a medication that increases appetite and hunger to balance kind of the healthiness versus that side effect of a medication?
That is an excellent question. And I believe that question would be most appropriate to talk to, if it's your child or someone else's child, to talk to that child's doctor in regards to the particular medication and the up in appetite. With that, I don't feel like I would be able to answer that question myself without like further insight. And I'm also not a medical doctor in regards to that piece.
Okay, thank you.
Thank you. Are your PHP and IOP services offered at a facility located in Temecula? Yes, we have a IOP and also a PHP location in Temecula. If anybody needed that type of service, they could reach out to me and I could support them throughout that process. It's a nice place. All right, any other questions? And anybody, and if Kelly or Lisa or Shante, if any of you have any questions, go ahead.
I'll ask another question.
Sure, yeah, please do.
Um, so in regards to like age and things like that, because some of these symptoms are when they're presenting all of that list of things to kind of look out for, can be kind of a gradual onset. What's kind of the timing or the amount that you're seeing some of these behaviors, or what are some of the guidelines to know like, oh, this is actually kind of hitting more of a red flag that we need some intervention?
That's a great question. And I think it's important as like if like say like you're a parent, it's important to follow your instincts. Like if you're concerned, reach out for help. Even if it's something that might seem minor, like I don't really know. I'm thinking maybe this might be a problem. Maybe not. Maybe it's nothing, but I'm not sure. It's best practice to reach out to a counselor, reach out to a therapist, and then they can do more of a clinical assessment to be able to determine whether a child would need a higher level of care or have outpatient therapy for the concerns, or they may have a clinical assessment and then say, hey, actually like everything's a-okay. But it is important again, sometimes when it comes to parenting, we may see something and be a bit concerned, and then see another thing, and then we may try to push things aside, or like, oh, it's going to get better on its own. But I think it's really important to ask for help earlier than when you see it snowballing. Because I think oftentimes in our society we have, this is our own opinion, but we have a lot of a kind of an independent mentality, like we're supposed to fix it ourselves. And that can be a contributing factor to a child, like you said, may have one thing and then another thing and another thing. And by the time they have professional help, it's a much bigger challenge than initially. So what I would say is reach out. Like for instance, when it comes to the school, you can reach out to a school counselor right away, and the school counselor can work with your child, or if it's somebody else's child that needs that type of help, and then they'll be able to treat appropriately and collaborate with the family.
There was another question in the chat, Elizabeth, about age limits.
Yes, great question. So typically we admit 12 and up. But I have seen us have some children, as I think the youngest patient I ever had was 9, but that was rare. So there has to be other particular factors. So it's not just we don't just admit all 9-year-olds, that we have to look at that case by case basis, but sometimes we can go as low as 9, but typically it's 12 and up. And we have adult and adolescent programs. So for instance, we might have a residential for adults. That like one of them's in Palos Verdes. And then we have a residential for children, or adolescents under 18. And then that would be like one of them would be in Alhambra. So they're separate. For the PHP IOP, sometimes the adults and adolescents are within the same site, but they're separated. They're like in the same location, but they're on separate tracks.
And then just as far as just a general question, does the Center for Discovery accept insurance? Like when I call, like how do I figure that part out if my child does need support?
Oh, great question. And we take so many insurances. That's something I love about Discovery. We take a ton of insurances. I don't actually have the list all here. Shantz, I do have the list all here. We take a lot.
We do take IHEP, which is great for that area, and we take that for adults and for adolescents for our Center for Discovery. So that's and Kaiser. So those two, and we're a network with pretty much everyone else, but those two are the major ones that you'll see in your area. But if you just give Elizabeth a call, and give her the information when you guys need that assistance, she'll be able to make sure that insurance works with us.
Thank you, Shante. Yes, most major insurance providers, especially PPOs, we can take, including the IHP and Kaiser. We unfortunately at this time we do not take Medi-Cal unless it carves out into IHP. But that's an awesome thing that it can carve out into IHP, and then we can take it. So if you are on Medi-Cal, I encourage you to apply for IHP. Oh, I appreciate the thank yous. Thank you for being here. I'm going to share some resources. All right. This part gets me excited.
There's another question in the chat about Kaiser. If you guys are able to answer that one.
Kaiser doesn't have to be referral from primary, or can it be self-referral? Great question. Kaiser does have to refer it. So, so you can reach out to me. But then we also do need to get the referral from Kaiser. So you're going to want to talk to a primary care practitioner at Kaiser, the main practitioner that's assigned to the person that needs the care. And then Kaiser will collaborate with us. The IOP program hours vary based on the program. For Temecula, I actually wish I had that off the top of my head. I don't at the moment. Shante, do you know the
So Temecula is 8 to 3, Monday through Friday.
8 to 3? That's the IOP hours?
Mm-hmm.
Okay.
That's a PHP through IOP right now. There, the census is combined. So, yeah.
Okay, that would be the PHP hours. So the IOP hours would be within that, but they're not.
Yes, correct.
IOP hours are specifically.
I don't, because I think they're kind of doing something different right now due to the census. So I'm not sure what their IOP. I think they just are doing PHP right now.
Okay.
I think that's what the census calls for.
Got it. Okay, thank you, Shante. So when it comes to IOP, we don't have that right now off the top of our heads, and we apologize for that. Discovery has over 150 locations. So as a rep, we don't typically memorize all the schedules of the 150 locations, but we can find out that question. So the person who asked me the IOP program hours, please reach out to me. I'll give you my information and I will get back to you and give you those hours. Okay.
And then could I just add something on? I know you talked earlier about the academic piece. So just so for people who are here and want to know, within Temecula Valley Unified, if your child is participating in an IOP or a PHP, we do have academic options to support as well. So I know a lot of parents worry about missing that time at school or with friends and those kinds of things. So if that is your situation, you can always reach out to our office and me directly as well, or to your SEL team member or the administrator at your school site, so that you can discuss what those academic options are based on the support. Because I know 8 to 3 is right in the middle of that school day. And so we get worried about missing school, but just know that there are options available for students who need that level of care.
Thank you so much, Kelly, for sharing that. That's so important. You got a whole team of people who care.
Absolutely.
So important. Thank you.
No problem. And I saw another question come into the chat.
Great question. And no, you don't have to start with PHP. So the way we make placement is based on APA guidelines that are created by the state of California, and it has to do with clinical and medical. So when a patient comes into Discovery, they're going to have certain medical pieces submitted to one of our doctors. This would include lab works, EKG. So our doctor's going to look at all of that. They're also going to look at the clinical piece, and they're going to do an assessment with your child, or if say it's an adult with the adult. And when they do the assessment, they combined the clinical and the medical insight to determine what's the most appropriate level of care. That that is starting at IOP. Sometimes that's starting at PHP. Sometimes that's starting at RTC. So it really varies based on the person and what they're going through and their experience. And then sometimes it's outpatient. So that someone calls Discovery and we're like, let's get you an outpatient therapist. So it doesn't always, it does not always IOP or PHP. It can be a lot of different possibilities. Sometimes somebody will start at PHP and then they will gradually go to IOP and then go to outpatient. Sometimes people will go to IOP and then go to outpatient and they've never gone to PHP or RTC. Sometimes a child's had no care and they go to the hospital and then we see them after they step down from the hospital. So there's lots of different variations. I like to think that going to outpatient right away is the best if that is possible. But if a child needs a higher level of care, then it's really important to get it sooner than later. Because often when a child, like say a child needed IOP and they don't have it, then it's much more likely for them to eventually need PHP, RTC, or hospitalization in the future. So it's good to start at a lower level when the child needs it, then wait when they need a higher level. And during treatment, you may be curious, what happens in treatment? A child would have their own individual therapist assigned. Oh, we have a guest. I love that we have a guest. A fur guest, as you can see on Lisa's screen. They would have their own personal primary therapist assigned to them that would work with them in individual sessions and also family sessions, because family work is really, really important. They also would have groups. Groups would include shame resilience, healthy relationships, dialectical behavioral therapy. That really champions for distress tolerance skills. They'll also do CBT, which is cognitive behavioral therapy, ACT, acceptance commitment therapy. They also have a process group every day with a therapist. And that's something where they can talk about all kinds of things that are going on. Process group is pretty open-ended to be able to process different things that navigating what they're going through. They also have therapeutic meals, and that's really important. They have exposure therapy. It's called exposure response prevention therapy. And that is a therapeutic meal intervention for eating disorders. It's intensive, but it's also short-term. And the concept is to be able to get tools, learn the tools, get familiar with them. And so once they discharge and they graduate from our program, they can use those tools, continuing work with an outpatient therapist. And so our treatment's short term. It's not that long. So for instance, like getting pulled out of school, it's not like forever. It's just for a period of time until they get healthier, and so they can go back to school and work with their outpatient therapist. We also have a multifamily group, which I really love. It's when multiple families come in for a group. So I'm going to share the resource.
Yeah, and they actually have dinner together. So they have a family dinner night where all the families actually get to eat dinner together, and it's really good exposure for the family and the adult and the clients. It shows them how to eat, and I love the part that we do allow them to cook their own food. And that exposure again, Elizabeth, is everything. Cutting it, seeing it, touching it. It's such a good exposure, and it desensitizes their fears a little. So I love that part.
Yeah,
Sorry, go ahead with
that part is great, and it can really help with real time, because say a family has challenges when they're having meals at home, then we're bringing them in with a therapist that can support to intervene during those real time where there's moments the parent's like, what do I do? Okay, let's work on it right then. And it's really great. I love that you brought that up. Thank you, Shante. All right. Okay, so this is my information, also Shante's information. So if you want to write that down, that's our direct line. Oh, I realized, Shante, I didn't put your email on there. That was my mistake. I apologize. So if Shante, you want to put your email in the chat. Shante is the clinical outreach representative for our MH and substance use division. So say there's a child who could benefit from substance use, disorder support, treatment, and also mental health treatment in our mental health division, then you could reach out to Shante and she can help and support that. Right, and then we have resources, a free virtual support group. So Carrie, I was thinking about your question in regards to like, what do I do when it comes to reaching out for support if you see little things or like maybe what seems like little things, but you're not sure. One of the resources would also be reaching out to a support group. We have free support groups, supportandrecovery.com. And that could be a space to also get further insight and support. You can also reach out to the National Eating Disorder organization, their website, and their phone number is there. The phone number is also a hotline to be able to get support. Feast is also a support group for parents, specifically for parents, which is great. And then Project Heal, I love this nonprofit. They work to help people get treatment that systemically have not been able to get treatment due to racism and due to oppression and due to different factors that we want to end. We want to get treatment for everyone who needs treatment. And so Project Heal, they work with organizations to also offer full scholarships for treatment. And Discovery collaborates with Project Heal and gives full scholarships to different people who may need, say they may need RTC care and they don't have insurance, and they can go through Project Heal and be able to have the possibility of having a full scholarship. We also have a Spanish speaking virtual support group. And as you can see, I have the flyer right there. And so we have both in English and we have it in Spanish. I have my references here. And then that is the whole presentation. So thank you so much for having me. And I hope you all have a wonderful rest of your evening. It's almost 8 o'clock, which we're really good on time. Wow, watch out.